Welcome to Pediatric Podcast for PedsCases.com.
Hello and welcome to Peds Cases. My name is Aryan Riahi. I'm a third-year medical student at the University of British Columbia. Today, I have the pleasure of recording this podcast with Dr. Joseph Lamb, a pediatric dermatologist at BC Children's Hospital. This is a podcast discussing birthmarks in pediatric patients. Birthmarks are common discolorations of the skin that are present at birth or during the first weeks of life. Causes include overgrowth of blood vessels, melanocytes, fat, fibroblasts, keratinocytes, or smooth muscle. They involve an imbalance in factors that determine the migration of skin cells. Birthmarks can occur anywhere on the patient's body. Dermatologists divide them broadly into pigmented and vascular birthmarks. They vary in size, appearance, color, shape, and permanence. While many are non-cancerous, effective identification and management of birthmarks can improve quality of lives for patients and hopefully reassure their parents. After listening to this podcast, the learner should be able to do the following. Number 1, compare and contrast common pediatric vascular anomalies, including vascular tumors and vascular malformations. Number 2, compare and contrast common birthmarks, including congenital melanocytic nevi, dermal melanocytosis, sebaceous nevus, and Aplasia Cutis. Number 3, determine which birthmarks require diagnostic workup. Number 4, discuss complications of congenital melanocytic nevi. Number 5, identify key questions on history, physical exam, and management. Now, let's talk about how birthmarks can present in infants and children. Let's start our first case with an infant.
Case 1. History of present illness. Sarah is a 4-week-old girl who presents to the clinic with her parents, who are concerned about a bruise-like patch on her left shoulder that is growing. Past medical history. Sarah weighed less than 6 pounds at birth. She and her twin sister were delivered via an uncomplicated cesarean section. Family history. The mother is a healthy 34-year-old woman with no medication exposure during pregnancy. Do you know the 2 categories of pediatric vascular anomalies, and how can we tell them apart?
Good question. Vascular tumors are neoplasms of vascular tissue. All vascular tumors have a proliferative phase. While the growth of many vascular tumors eventually stop or plateau, sometimes they will not stop proliferating without medical intervention. Infantile hemangiomas are the most common benign vascular tumors in infancy, as they affect around 4% of infants. Vascular malformations are lesions involving abnormal blood vessels. They progress slowly and do not proliferate. Arteriovenous malformations are vascular malformations.
So when should the parents expect their child's infantile hemangioma to grow the most rapidly?
Infantile hemangiomas proliferate in the first 3 months of life, with the most rapid proliferation occurring around 5 to 7 weeks.
And what are some physical exam findings for infantile hemangiomas?
Well, infantile hemangiomas can be superficial, deep, or mixed. Superficial infantile hemangiomas are minimally elevated and have a bright red color. Deeper ones are larger than superficial ones and have a bluish color. Infantile hemangiomas can occur anywhere. While focal ones are most common, regional and segmental infantile hemangiomas or involvement of the head, neck, or lumbosacral regions may be associated with structural anomalies. So assess for complications of infantile hemangioma, including ulceration, vision loss, airway compromise, aesthetic complications, and structural anomalies such as PHACES or PHACES syndrome.
Very good. Now, what is the management of infantile hemangiomas?
Well, consider referral for rapidly growing infantile hemangiomas before 3 months of age. With respect to pharmaceutical therapy, oral propranolol is an FDA and Health Canada approved treatment for infantile hemangioma requiring intervention. It has been shown to reduce the size of infantile hemangioma, prevent further growth, and manage ulceration. While well tolerated, side effects include hypoglycemia, hypotension, bradycardia, and sleep disturbances. The most common complication is ulceration, occurring in around 10% of cases for infantile hemangioma. This is particularly concerning on mucosal sites, as 40% occur on the lip and anal genital region or sites with high tension such as upper back and arms. This is why it is important to look for heralding signs, such as early white discoloration or infantile hemangiomas that are large or segmental or regional. As ulceration can lead to significant pain and scarring, consider early referral to pediatric dermatologists. Provide wound care and pain control with daily soaking, crust removal, emollients, and pain control. Adjunct therapy such as oral propranolol to shrink the tumor and topical metronidazole antibiotics to prevent infection can also be considered. Should visual impairment such as astigmatism arise from pressure on the globe, consider systemic therapy and referral to ophthalmology. Involvement of the larynx can cause airway occlusion, which is a fatal emergency. Assess for the presence of hoarse voice and stridor. A paper by Orlo and colleagues proposed 5 cutaneous locations in the beard distribution as areas that are high risk for airway involvement. These include the left preauricular area, right preauricular area, chin, lower lip, and anterior neck. When 4 or more of these areas are involved, there is a 63% association with infantile hemangioma with symptomatic airway involvement. If warranted, start oral propranolol and or steroids. Refer to the emergency department if the patient is unstable and airway obstruction is present. If there are more than 5 cutaneous infantile hemangiomas, there is an association with hepatic hemangiomas. Abdominal ultrasound is warranted to screen for these. This is because while most hepatic hemangiomas do not cause symptoms, the larger ones can involve high output cardiac failure or even failure to thrive. Large hepatic or parotid infantile hemangiomas are associated with consumptive hypothyroidism, which is a fatal condition warranting treatment of infantile hemangioma. Aesthetic complications can occur from large hemangiomas that leave a fibrofatty remnant after involution. Residual infantile hemangiomas may also cause ulceration that may result in scarring and hypopigmentation. Consider early treatment of infantile hemangioma with propranolol to reduce these cosmetic complications and the later need for surgery. When surgery is necessary, laser and excisional therapy are both options. Finally, large, regional, or segmental infantile hemangiomas found on the face have a 30% risk of underlying PHACES or PHACES syndrome. This syndrome stands for posterior fossa abnormalities such as Dandy-Walker malformation, hemangioma, arterial or aortic anomalies, cardiac anomalies, eye abnormalities, and finally, sternal defects or clefting. If suspicion is high, echocardiography, ophthalmology evaluation, and an MRI of the head and neck is recommended to assess for complications. Please note that if you want to learn more about this topic, there is a full PEDS case podcast on infantile hemangiomas to check out.
Now that we have discussed a common pediatric vascular tumor, what are some common vascular malformations?
Well, Nevus flammeus is colloquially known as a port wine stain.
Correct. And that is an example of a vascular malformation. What is the pathophysiology of a port wine stain?
Good question. These are congenital malformations in the dermal capillaries. They're red macules that follow a dermatomal distribution and usually don't cross midline.
And what are treatment options for a port wine stain?
We treat these with laser for cosmetic purposes.
Another vascular malformation is a nevus simplex, which is colloquially known as a salmon patch. What is the pathophysiology of a nevus simplex?
Well, simply put, they are due to congenital dilation of the dermal capillaries.
And how does a nevus simplex present clinically?
Nearly 1/3 of newborns present with these pink or red irregular patches. They tend to occur in the glabellar area, nape of the neck, and occiput. However, the majority of these cases regress spontaneously. This concludes the end of case 1.
Let's move on to case 2. Here's the history of presenting illness. Rosie is a 2-week-old girl who presents to the clinic with her parents as they are concerned about a large brown area on the right calf. The parents would like to know if this is malignant. Past medical history: Rosie had an uncomplicated birth. She was a full-term baby and underwent vaginal delivery. Family history: the mother is a healthy 34-year-old woman with no medication exposure during pregnancy. What are some physical exam findings for congenital melanocytic nevi?
Well, congenital melanocytic nevi can present with macules, papules, and plaques, immediately noticed at birth. The color is often tan, dark brown, or black. The texture can vary from smooth to cobblestone-like appearance. The hair on these lesions can be present, but sometimes there is no hair. Pigmentation can develop over time. The size ranges from small, with diameters of 1.5 centimeters or less, to really large, with diameters of 40 centimeters or more. The most common congenital melanocytic nevi are small. The lesions tend to grow in proportion to the patient.
So what is the management for congenital melanocytic nevi?
Well, malignancy potential depends on size. Small and medium-sized congenital melanocytic nevi have under 1% potential to transform into malignancies. However, larger or giant congenital melanocytic nevi have an estimated risk of about 2%. The risk of malignant transformation is even greater if there are satellite nevi. While the diagnosis is clinical based on morphology and natural history, biopsies are sometimes taken to rule out melanoma. Overall, the risk of melanoma is low, so it is usually a secondary reason that prompts its removal, such as cosmetic complaints or irritation. Prophylactic surgery is not effective in eliminating the risk of melanoma. because 50% of melanoma in children with congenital melanocytic nevi occur at sites distant from the nevi itself. Excision is mandatory when a melanoma develops from a congenital melanocytic nevus. Routinely, check these congenital melanocytic nevi, especially after puberty, to monitor for progression to melanoma. This marks the end of Case 2.
Case 3. History of presenting illness. Louis is a 2-year-old male of Hispanic descent who presents with a large dark gray patch on the lower back extending to the buttock. This patch has been present since birth. He is otherwise healthy. Past medical history reveals he's full term, born from an uncomplicated vaginal delivery. Family history reveals he has an older sister who's 10 years of age, who was born with a similar patch, but no longer appears to have this pigmentation. What is the pathogenesis of congenital dermal melanocytosis?
Congenital dermal melanocytosis represents melanocytes becoming trapped in the dermis while migrating from the neural crest into the epidermis.
And what are some of the physical exam findings for congenital dermal melanocytosis?
Well, these lesions are evident within the first few weeks of life. They present since birth. They are more common in patients with darker skin types. Most commonly, it's a single lesion, but there can be multiple congenital dermal melanocytic lesions. Distribution is usually focused around the lower back and buttocks.
And what is the management for congenital dermal melanocytosis?
Well, once a clinical diagnosis is made based on history and physical examination, no workup is needed, at least not routinely. Rarely consider workup for rare metabolic disorders such as Hurler syndrome or GM1 gangliosidosis. In these cases, extensive congenital dermomelanocytosis or failure to thrive could be the first initial presentation. Most cases of congenital dermal melanocytosis self-resolve by 10 years of age. This marks the end of Case 3.
Case 4. History of present illness. Eli is a 3-year-old male presenting with a hairless lesion on the right side of his forehead, proximal to his right eyebrow. Past medical history, he had an uncomplicated, full-term vaginal delivery. No medications were taken by the mother throughout the course of her pregnancy. What is a Nevus Sebaceous?
A Nevus Sebaceous is a benign neoplasm consisting of epidermis, hair follicles, connective tissue, and apocrine glands. They are relatively common, found in about 0.3% of newborns.
And what are some of the physical exam findings for a Nevus Sebaceous?
Nevus Sebaceous is primarily found on the scalp and face. They appear as single, yellow or orange colored, smooth, oval-shaped patches without overlying hair. They appear even more bumpy or scaly as the child reaches adolescence.
And what is the management for a Nevus Sebaceous?
A clinical diagnosis based on history and physical examination is often sufficient. While the risk of malignant transformation into basal cell carcinoma is low, the possibility exists. Therefore, the lesions should be monitored. Sebaceous nevus syndrome is a rare disorder seen with large nevus sebaceous that is associated with skeletal, neurologic, and ophthalmologic abnormalities. Biopsy is warranted when cases are atypical. Finally, surgical removal should be considered when changes are observed with the lesion including a new warty growth, lump, or sore that fails to heal. This marks the end of Case 4.
Case 5. History of present illness. Tricia is a 30-day-old female who presents with an ulcer at birth on the scalp that has now healed but has left behind skin changes. Past medical history: she was born via full-term, uncomplicated vaginal delivery. Her mother is a healthy 30-year-old woman with no medication use throughout her pregnancy. What is Aplasia Cutis congenita?
Well, Aplasia Cutis congenita is the localized or widespread absence of skin from birth. All genders and races are equally affected. The incidence rate among newborns is approximately 2.8 in 10,000.
And what are some of the physical exam findings for Aplasia Cutis congenita?
Aplasia Cutis congenita presents with well-demarcated lesions of various sizes, ranging from small to large, and their shapes can vary, ranging from circular to linear. Bullous aplasia cutis is when membranous epithelia cover the lesion, resembling a bulla. Aplasia cutis congenita can affect any part of the body, but 86% are on the vertex of the scalp. Most cases are single lesions. Paired lesions are the second most commonly seen presentation. One should be suspicious of neural tube defect if the lesion is midline or if there is a hair collar sign present. A hair collar sign consists of a dark tuft of hair surrounding the periphery of the defect on the scalp.
And what is the management for Aplasia Cutis congenita?
Good question. History and physical exam are often enough to make the diagnosis. No further investigations are needed. Not all cases of Aplasia Cutis congenita require imaging. But if there is a hair collar sign, midline defect, or other palpable bumps or lumps underlying the Aplasia Cutis congenita, this is when we consider imaging for deeper embryologic defects affecting the bone, vasculature, or soft tissues. Also, consider genetic counseling for the parents if additional anomalies are found on imaging. Most cases of Aplasia Cutis congenita carry an excellent prognosis. Often, gentle cleansing and applying topical antibiotics or ointments to prevent infection is enough. However, in cases where size, depth, or location of the cutaneous defect is substantial, such as with Aplasia Cutis congenita involving the periosteum, dura, or bone, then additional precautions must be considered. In cases of multiple or large defects, consider referral to neurosurgery for surgical closure. This marks the end of the last case. Let's summarize what we've learned today. First, infantile hemangiomas have a variety of complications depending on their location. Lesions with a segmental presentation and large facial lesions over 5 centimeters require MRIs of the head and neck, echocardiograms, and ophthalmology exams for associated facies or PHACES syndrome. Non-segmental lesions are unlikely to be associated with facies syndrome, regardless of their size. Central facial lesions can have an aesthetic concern for the patient. Periorbital involvement can lead to visual compromise, amblyopia, and astigmatism, which warrants ophthalmologic evaluation. Laryngeal involvement may cause airway occlusion, which is a fatal emergency. Assess for areas that are high risk for airway involvement. Also, assess for hoarse voice or stridor. Second, a congenital melanocytic nevus is a benign proliferation of melanocytes. It presents as pigmented macules, papules, or plaques. Hair may be present, but not in all cases. Follow large or giant congenital melanocytic nevi for the risk of melanoma developing later on. Third, congenital dermal melanocytosis involves entrapment of the skin's melanocytes in the dermis. This presents as a bluish-gray pigmentation with poorly defined borders, most commonly appearing in the buttocks and lower back. Typically, they are benign. Fourth, Nevus Sebaceous is a congenital hamartoma of the skin. It is defined by hyperplasia of the epidermis, hair follicles, and sebaceous and apocrine glands. It presents as hairless yellow plaques. They are more visually apparent in adolescence. Finally, Aplasia Cutis congenita involves an absence of skin from birth. These may present with ulceration, erosions, or scars. Further imaging for a possible neural tube defect is warranted if you notice a hair collar sign. Well, that wraps up our podcast series on birthmarks. We hope you're now feeling more confident in identifying these high-yield birthmarks, including infantile hemangiomas, congenital melanocytic nevi, congenital dermal melanocytosis, nevus sebaceous, and Aplasia Cutis congenita. As for our references, we would like to acknowledge the following sources where pictures and statistics were drawn for this podcast. The visual references were used for educational purposes. Thanks for listening.
Check out www.pedscases.com for more great podcasts, videos, interactive cases, questions, and more. Press subscribe on iTunes to get access to all of our podcasts. If you like what we do, please leave a review on the iTunes store, share with your friends and colleagues, or think about getting involved.